it's a very, very important topic when you look at intensive care management. Okay, and the first thing starts that we don't know much in acute kidney injury. That is the first thing, we don't know much. Okay, so when we talk about creatinine, serum creatinine, it makes a lot of sense when we are actually dealing with chronic kidney disease. Okay, when you talk about serum creatinine. For example, if the patient's urine output drops today it's zero urine output, or there is no functioning kidney today. Okay, now there is no functioning kidney. What will be my creatinine tomorrow? Say I am normal. Say my creatinine is say 0.9. Okay, my creatinine is say 0.9. Okay. Alright, my creatinine is say 0.9 today. Okay, and now my kidney actually fails from working. What will be my creatinine tomorrow? What will be my creatinine? What do you feel? Kancha.
So it will rise and not get excreted.
How much? So generally
three times.
Yeah, Ashok, anything?
According to grading.
Now how much will it rise? I'm just asking a simple question.
3 times. Baseline.
The kidney is normal, and today my kidney has failed. I'm telling you the kidney is failed. It is not working at all. How much will it rise?
3 times the baseline.
It will rise only by 1 milligram per day. Okay, it will rise only by. This is what you must understand. Okay, ऐसा नहीं है कि it is not this way that if my kidney fails, my creatinine will be 10 and 11. You understand? It is not something that is going to occur. Your kidney is going to rise only by, creatinine is only going to rise by 1 milligram per day. This is the fact. Okay, it's not going to be much more than that. What I am trying to tell you is, creatinine cannot be taken as a real marker of injury because of this reason, that creatinine does not follow everything quickly. You understand? And that is why, if you look at the KDO classification that she said, you actually said 0.3. You actually said 0.3 milligram per day, isn't it? You said 0.3. And you added another marker, which is the urine. You understand? That's why you added another marker to call about acute renal failure, because there is a combination of either the creatinine going up or the urine output being less than 0.5 ml per kilogram per hour for 12 to 24 hours. Isn't it? Similarly, when the creatinine goes up between 1.5 to 1.9 or goes up from 2 to 3 or more than 3, that is how it is staged into stage 1, stage 2 and stage 3 acute kidney injury from the KDO classification. But what you must understand is why you use the creatinine. The creatinine is generally a marker for chronic kidney disease. When you have chronic kidney disease, by looking at the creatinine you can understand, okay, the creatinine has gone up, need download or something. You look at the treatment parameters based on the creatinine there. You don't look at the treatment parameters based on creatinine only. Clear? So in an acute state, creatinine clearance does not make any change for us. Now it's such an important implication for us. Why is it an important implication? Because one of the few things that we do in intensive care is to actually get the right dose of the antibiotic. One of the things that we want to do in intensive care is give the right dose of the antibiotic, because what we said in this case was the fact that many of these antibiotics are actually nephrotoxic. Many of these antibiotics, take it vancomycin, take it ceftriaxone, take all of these antibiotics, they are essentially nephrotoxic. They are essentially like poison. Okay, now if you now decide the dose based on the creatinine clearance, what we have understood is creatinine is not the mirror of the kidney function. What we have understood now? Creatinine is not the mirror of the kidney function. For example, as I told you, when the kidney is completely failed also, creatinine is going up only by 1 milligram per day. Okay, and our creatinine clearance equation that we call weight minus 72 upon serum creatinine, 140 minus age and all these things is based on serum creatinine. Are you understanding? That is why in an intensive care unit, our creatinine clearance may not be a great judge to think about antibiotics, to dose adjust antibiotics. You understand? Dose like amphotericin, like voriconazole IV, drugs like vancomycin, It's so difficult to dose them because creatinine is the only way it has been told in literature. Okay, so when you open a package insert, the dose modifications will be based on renal, where there is creatinine tolerance less than 10, 10 to 30, 30 to 50, more than 50, like that will be written in that, and you'll have a dose. So why is that written? So that is based on chronic cases, chronic kidney disease. So if you have a patient is essentially having creatinine of 5 for ages and ages, then you can follow that formula very well. Unfortunately, we cannot follow that formula very well in acute kidney injury. It's just a guide. It's just kind of a guide. Are you understanding? So today, if the patient's creatinine goes tomorrow to from 0.6 to 1 to 1.6, it can be even renal failure completely. And the essential function that we are thinking about by talking about GFR may be even less than 10. What are we trying to assume? Estimated GFR, no? Estimated GFR. And that is how we are calculating by the creatinine clearance equation. Estimated GFR. And all our thing that we are based on our antibiotics is based on estimated GFR. Are you understanding this? It's estimated. It's not the actual GFR. So that is why when we are looking at antibiotic dosing in intensive care, we don't know much. You understand? And that is why we end up, on top of it, you add so many other things, excessive volume of distribution, excessive volume challenges that we are giving. All this is going to dilute everything. The albumin that is on the lower side, it's not going to be protein binded. So there are so many other things that are coming into the equation that this itself may not be the right way to do stuff. You are understanding? So that is why when you are diagnosing acute kidney injury, we are actually putting two things together. We are putting the creatinine as well as putting the urine analysis, urine output to actually go together and say, okay, we are going towards acute kidney injury. Understood? Any queries till now? Any queries on this aspect till now? No. So let me give you an example of a patient who's come in now. Okay, he's a 60-year-old gentleman who basically presents to us with a respiratory tract infection. And you decide, when the patient comes in, you figure out that the patient's blood pressure is 90, he's in septic shock. You follow the surviving sepsis stamping guidelines. Heart is normal, so you give him 30 ml a kilogram of fluid, maybe 20, maybe 15. After putting lines and doing pulse pressure variation, you've done all these things. Okay, and you have come to blood pressure of 110. Now there is no urine. What is going to be your next step, or how are you going to investigate this person? So we are dealing with a case of acute kidney injury, where we have this patient who is a 60-year-old gentleman who previously had no problems. He had no problems. He was comorbids, there were hardly any comorbidities that he had. And in that bargain, he has actually had a respiratory tract, a 60-year-old gentleman who had a respiratory tract infection, who came into the hospital with a 90 systolic blood pressure. Okay, you have resuscitated this patient and the blood pressure has come up to 110 systolic. Okay, and now there is no urine output. Very simple thing, the ICU that happens. How do you approach this patient? How is your approach? So you did mention a few things there. So I want you to tell me how you go approach. You did mention a flow chart here, which is very important. How do you approach this? Now what do you do here? So you have a problem right from diagnosis to understand why there is acute kidney injury or whatever nature, urine output is low. Okay, and then you have to decide the treatment, isn't it? So how do you evaluate this guy?
Sir, I'll first see if it is oliguria, that means 0.5 kg.
Urine output is low. Yeah, give me the data. Urine output is low. Now what do you do? So you have a patient in front of you. His 110 systolic has come in after fluids. Okay, he has respiratory tract infection. He is breathing heavily, no doubt about it. There is some acidosis that is there. We needed a blood gas. Okay, and now the urine output is low. And you have done all this. You have done all these fluid challenges based on putting in a pico monitor, seeing pulse pressure variation, looking at all the kind of techniques you could do, cardiac output, passive leg raise, and all these things you have done, and you have optimized the amount of fluid that you need to give. Now what do you do? How do you approach the case?
USG.
Yes, that is the first thing. So what you did mention on the screen was first thing was USG. So you cannot follow that when you have an algorithm now, you have to have an algorithmic approach. You cannot do critical care without following an algorithmic approach because it's very simple. You can make it very difficult, but you are responsible for making it difficult. Actually, critical care is very simple. It's algorithmic. Every disease has got an algorithm. Alright. So what you do over here? Do a USG. Now tell me, why do you want to do this USG concern? You are right. You want to do a USG. Why do you want to do this USG?
So I want to check if there is a urinary retention, that the patient is having some, is not able to pass urine, or really there is he is anuric, there is a bladder collapse.
Right. So 10% of the entire group will have a post renal injury. Only 10%. Only 10% will have a post-renal. Post-renal, you know, it's a pre-renal, renal and post-renal. Only 10% will have post-renal. So when I do an ultrasound, what am I looking at? I'm first looking at the bladder. Okay, I'm looking at the bladder. Okay, if I'm looking at the bladder, is there some kind of physical obstruction to the catheter? Simple. That is the first thing I will look. Is there a physical obstruction that causes the bladder to distend? Okay, that means the urinary tract ahead, the Foley's catheter is blocked, caved, stopped, whatever. Okay, so this is one part of the story, physical obstruction. Very simple thing to relieve. You might resuscitate, but the patient is not passing urine. Don't just give more fluid. Check the ultrasound. 10% of these cases may have just a physical obstruction. A simple thing that will just get relieved the moment you open up the obstruction. Right? Then the next thing that you want to look at in the bladder is the fact whether there is bilateral hydronephrosis. This is acute kidney injury. Unilateral hydronephrosis will not cause acute kidney injury. Because you have one kidney that is normal, you will never come to a situation where you have urine output that is going to be low. So what you need to see? Bilateral hydroureter or hydronephrosis. For example, you had a retroperitoneal tumor, that is pressing on the ureter bilaterally, large tumor, which is causing this kind of a problem. You understand? Or you have a bladder tumor, which you are unable to see on the ultrasound, which is causing bilateral obstruction, ureteric obstruction. Or you have a fibrotic band on both the sides, which is causing hydronephrosis. So very rare. So what you can understand, a post-renal cause is actually very rare. The post-renal cause is actually very rare. It is not something that you will get, but it is something that if you get, you can relieve quickly. You understand? Because there is urine. It is essentially not acute kidney injury. Urine is there. Unfortunately, it's not coming out. Are you understanding? For example, the guy who's down there, the person over there, Singh. Okay, what has happened to him? He is in acute kidney injury. Why does he have acute kidney injury? Because he had bilateral hydronephrosis. Bilateral hydronephrosis he had. What was done? They did a PCNL. He is passing urine. Okay, he is passing urine. It is not chronic kidney disease. It's acute kidney injury. It's acute kidney injury that is getting relieved because it's a post-renal cause. It's an obstruction which is relieved. That's why the PCNL is draining. Are you understanding? So, he's in that 10% variety which has got the post-renal causes for renal failure, for acute kidney injury. Clear? So, an ultrasound will only tell me this, and it will also tell me the kidney size. What it does with the kidney, of course, there is a lot more you can do with the ultrasound, but let's not go into another thing like resistive indices and all these things. We will not go to all those things. Basic. The basic says, get an ultrasound. In the ultrasound, look for whether there is a bladder. If there is a bladder, search for a kink. Search for an obstruction, take it out. It is just a physical problem here. Or if there is a hydroureter or a hydronephrosis bilaterally, then I'm going to look at the fact that whether there is something further I need to evaluate. I need a CT like how we did for that guy. I need a CT to figure out what's happening here. And then PCNL and whatever you should do based on what you get over there. Clear on the ultrasound? There are many more things you can do on the ultrasound, okay? But this patient did not have a creatinine that was bad. So you are not expecting his kidneys to have chronic kidney disease. Are you understanding? You are not expecting this kidney to have chronic kidney disease. It's a normal creatinine he had. It's an essentially normal, healthy individual who came into you with a respiratory tract infection, is shock, and this is what the situation is. So you are not expecting the kidneys to be small and all those things. It doesn't come on in your mind. So don't confuse your mind by saying I'm going to look at the kidney size. For small kidneys, we are looking at for normal kidney, hydroureter and hydronephrosis. Clear? Now what's the next thing you want to do here? Exactly. So that's what the algorithm said. Urine analysis. Now, What exactly are you looking at the urine analysis for? Elizabeth, you're looking at urine analysis. What are you looking for? You're right.
So I want to know if there is interstitial injury or
Okay, you want to know if there's interstitial injury. Alright. So what are you looking for?
cast,
Cast. But what cast?
RBCs. What do you-
hiding.
No?
RBC caster.
No? So when you're doing my urine analysis, I'm looking for cast, you're right. I'm looking for proteins. There are two things I'm looking for. I'm looking for cast, I'm looking for proteins. Mind you, this is not a patient of urinary tract infection, no? This is a patient of respiratory tract infection. And I'm looking for figuring out whether I have a cause for his acute kidney injury. Do I have a cause for acute kidney injury? For that I'm doing my urine analysis. So in my urine analysis, what I'm looking for cast, I'm looking for protein, and I'm looking for RBC. There are three things I'm looking for. Okay, now why are these things over here? So if I'm looking for urine analysis, I'm going to look for one cause. There will be one cause that causes acute kidney injury, and that you can diagnose on this. You can diagnose an acute glomerulonephritis on this. Okay, so if you have an acute glomerulonephritis from reasons that might be ranging from vasculitis to SLE to whatever, glomerulonephritis, Goodparcher's disease, these are all features that cause glomerulonephritis, which in this patient can be a part and parcel of the acute kidney injury. You understand? It may be a part and parcel of it. So don't think that acute kidney injury is always hypovolemia. It's not like that. Okay, so this could be a situation that ideally, because if I am not going to have water for a long period of time and I don't have a kidney damage, if I drink water should come. Essentially, logically, it is like that, right? But similarly, this patient's kidney is normal. But at the end of the day, when the patient is suddenly drawing urine, there has to be some problem somewhere. Okay, so what could be the problem? Acute glomerulonephritis, various causes, ANCA-vasculitis, vasculitis, Goodparcher's syndrome, anything will actually cause what? Will actually cause the release of RBC cast. This is what you're going to get. Okay, you're going to get RBC cast. So the moment I do a urine analysis and I find proteins to be high, 4 plus, proteins to be high, and I have an RBC cast, now what do? I am looking at glomerulonephritis. I'll start evaluating by glomerulonephritis की तरफ जा रहा है. Proteins are high. You're understanding? Proteins are high, RBC cast is there. This is glomerulonephritis. So this patient may not improve with your essential management. He'll not improve the next amount of fluid. In fact, he'll worsen. You understand? What about the other part of the story? So if this patient has got interstitial nephritis, when you said interstitial nephritis, it's very different. Glomerulonephritis is what the glomerulus has a problem. When you say interstitial nephritis, acute interstitial means interstitium has a problem. Okay, so when you have acute interstitial nephritis from any kind of drug, for example, you give vancomycin, nephrotoxicity is caused because of interstitial nephritis. You understand? There is some kind of medicine that is taken from outside called interstitial nephritis. There is a disease that's called interstitial nephritis. In that case, what you're going to see? You're going to see the same situation with an RBC cast. In fact, there will be more of WBC casts here. And there will be proteins that are there, but it is going to be lesser. The proteins will be lesser, maybe 1 plus. Okay, but you will see WBC casts. Clear? Acute interstitial nephritis, am I clear on this? Acute interstitial nephritis? Yes, regular AKI that is causing nephrotoxicity because of being ischemic for a long period of time will actually cause the release of muddy casts. I will see muddy casts there. I'm going to see muddy casts, right? So, and the last part is very important. So, if you have a patient who's been elderly at home, had a respiratory tract infection, has not taken food for a long period of time, remained on the bed, somebody has brought him back to the hospital, you have resuscitated, blood pressure has gone up and the urine output is not okay, you should always think about rhabdomyolysis. Okay, so when you think of rhabdomyolysis, what do? I do a urine screen and I figure out how many RBCs are there. If there are no RBCs, but I do a hemodex, I do a hemostatic monitoring. मतलब मैंने एक strip डाल दिया to find out the hemostatic monitoring, and I find there that it is positive. If I find there that is positive, what does it go towards? Rhabdomyolysis, because this is myoglobin. This is not hemoglobin. This is myoglobin. You understand? So I will find RBCs to be almost negligible, not there, but I will find this to be very positive. Right? So this goes towards the feature of rhabdomyolysis. Right? Anything else you want to do here? So she did mention about a very important investigation which we consider to be important, fractional excision of sodium, where you send urine sodium and urine creatinine and things like that. It is not supposed to be done. It was done in the past. We used to do all these things in the past. We used to do fractional excision of sodium. It's basically urine creatinine into serum sodium into serum divided by serum creatinine into urine sodium. It's like that. Okay. However, we are not doing this FENA anymore because we found out that it doesn't really add to anything. So initial algorithms all had FENA. Are we doing FENA in our hospital? We're not doing it, right? So what we're doing in our ICU is what is actually evidence based. Remember this. Okay. So if you're going to say on your algorithm FENA, are you doing it in your ICU? No. So you are asking this question, why are you not doing this? We're not doing this because of the fact that it is no longer said to be giving the right results. You understand? So we are not wanting the FENA anymore because it doesn't add to anything that we want. It doesn't add to anything that we want. Clear? It doesn't make any difference. That's why we are not doing fractional excision of sodium. So you can very well take it out of your mind. Tomorrow, if in the exam, you can just ask as an MCQ to understand what it was. But otherwise, on a practical aspect, I don't think there is any role of an FENA to be done over here. Clear? So what have we gone through? We have gone through an ultrasound to begin with. We have then gone through what? We have gone through urine analysis. So now, the first thing I will want to do is my drug management, my medication management. Okay, will I change my drug doses? Will I do anything like that? All these things comes in my mind. We already discussed the fact that there is going to be definitely a situation here we don't want this to be done with the drugs. So on the safer side, whenever you have a patient with AKI, with a respiratory infection or any kind of infection on AKI, you always want to updose. You don't want to reduce your doses. First day, I don't want to reduce my doses. You understand? I don't want to, because I know now that creatinine, I don't know whether that is right, wrong, what is happening, I have no idea. So the first day when I'm actually actively resuscitating my patient, imagine I'm giving tons of fluid into a compartment, okay, and now I put an antibiotic into it. The existing antibiotic will dilute off, right? It will get diluted off. So it doesn't make any sense to actually give a low dose or an adjusted dose of any antibiotic to begin with. It does not make any sense. Are you understanding? That is why I will give the original dose of the antibiotic to begin with. That's why we don't reduce loading doses. That's why we don't change the first day doses. We see what happens in second day. More often than not, when you give your dose of antibiotic, the creatinine next day will actually reduce, will get better. Urine output will start getting better because you're treating the cause. The cause is infection. The cause is inflammation. So when you're treating the cause, more often than not, the next day the creatinine will rather get better. Urine output will start coming in more often than not. Right? So also and then I don't know. If you ask me what is the dose, I don't know. But what I will not do, I will not reduce my doses. What is the actual dose, I don't know. Okay, but what I will not do, I will not reduce my doses. So the first thing I will say is adjustments of antibiotics. On adjustments of antibiotics, we have understood what is to be done. Adjustments of drug doses. We just now discussed this. Okay. However, if you have a patient of CKD, that's a different ballgame only. CKD comes with a respiratory tract infection, that's a different ballgame. There you have to increase it just because you know that's a stable creatininosis. Like for example, you have a patient on dialysis. He has come to you with a respiratory tract infection. There I know how to give this usually. I might give a loading, but I will adjust everything else. You understand? I will adjust. That day only I will adjust it. Clear? I will give the loading dose, but then I will adjust it immediately because I know that's a steady state. In a steady state, the creatinine is, what is the creatinine? Is the actual creatinine. Okay, so Sachin, you have this patient who has come to you. What is the next step? You have done these two things. What is the next step? Of course, apart from this, what are the laboratory investigations you want to send?
Electrolyte.
Electrolytes. So what electrolytes are you talking about?
Sodium and potassium.
Everything.
Sodium, potassium.
Everything. Sodium potassium not the only electrolytes. When you have a
Serum,
patient
serum,
what is your
calcium,
kidney
magnesium.
doing? It is doing all your electrolyte imbalance related problems it is curing. Everything that is related to electrolyte imbalance it is curing, right? It is not working properly. So you need to know what is happening. So what will I send? I will send sodium, I will send potassium, I will send
Serum,
calcium,
calcium,
I will send magnesium, I will send phosphorus.
Phosphate.
I will send all of these. So when you have an acute kidney injury, I want to see all of these because I don't know what is happening to any of those because it is not in our control anymore. It is not in the patient's control anymore. So that's why we need to take an external control over it. So if a patient comes with AKI, I want to send these to understand where am I lying. With creatinine, can I understand? No. With urine output, can I understand? Maybe, maybe not. So I need to understand what is happening. That's why we are sending more investigations to understand what is happening with these electrolytes. Are you understanding? Each of these electrolytes can be responsible for death. Each of these electrolytes can be responsible for change of treatment. Each of these electrolytes can be responsible for death, and each of these electrolytes can be responsible for change of treatment. Clear? That is why you need to send any of all of these electrolytes. Clear? Any doubts till now? So Sachin, now what do you do? You go to the labs. Of course, CBC is a routine. We are concentrating on our patient of acute kidney injury. What do we do now further? Labs are done. What do you do now? You have to manage. Patient is in front of you, respiratory tract infection, 90 systolic blood pressure, you've given fluids, 110 systolic blood pressure, urine output is low. Next, what do you do?
Sir, we'll try Lasix.
Try Lasix. Anybody? Sorry? So the entire point that we're trying to make is, do we give fluids further? Do we give fluids further? Second is what she said, do we give vasopressor or inotropic support? And what he said was giving
Diuretic.
These are the three things that are coming into our mind. The query is, do we give fluids? Do we give vasopressor support or inotropic support, or do we give a diuretic? Right, this is what is coming to us. So let's come to the first topic, fluids. What do we do? Do we give them fluids or do we not give them fluids? Essentially, if there's a pre-renal issue, after the resuscitation, this is only resuscitation. Remember this, when you have resuscitated your patient, the blood pressure will go up for 1.5 hours, after which it will come down again. Remember this, if the patient is hypovolemic or if the patient is septic, the fluid infusion will cause your blood pressure to go up and subsequently come down. It doesn't subsequently come down only when your antibiotic starts working. Otherwise, 1 liter of fluid today I give, 45 minutes later it will be in my interstitium. Are you understanding? So today if I take Supriya, make her sit over here, give her IV fluid and I check the fluid will not be in her vascular system after 1 hour. Are you understanding? This you must understand, it's a very important thing. But if you are talking of acute kidney injury and say we have a case, if this patient was having has not eaten food for the last 3 or 4 days, a 60-year-old gentleman, no wife, sitting at home, respiratory infection, unable to breathe properly, and he has not had his food for the last 3 days, 4 days, not drunk water. Essentially, he's dehydrated, isn't it? Essentially, he's dehydrated. On top of it, say he had an episode of vomiting and diarrhea, for example. He is essentially hypovolemic. Your initial resuscitation has only cured his resuscitation for that particular time. He still has ongoing fluid loss. He still is not having his food. He is still hypovolemic. So that is the patient in which I would want to give IV fluids. I have to repeat the IV fluids. And of course, I will repeat my IV fluids based on many other things. For example, my pulse, my passive leg raise related change. Passive leg related change. I look at my Vexus score. That means I look at my IVC, I look at my hepatic veins, I look at my portal veins. And depending on that, I will decide on the fluid responsiveness. Fluid responsiveness means giving fluid and 10% increase in cardiac output. That is fluid responsiveness. But this patient essentially is hypovolemic. If this patient is hypovolemic, I will try to give her the IV fluid. Now, which IV fluid would I want to give? This is a patient of acute kidney injury. This patient is an acute kidney injury. This patient has already received a resuscitated fluid in the recent past. You have sent these investigations. So which IV fluid would you want to give? So you got a whole lot of IV fluids that you have. You'll have to decide which IV fluid you want to give, what should be the ideal one. So what do you think should be the ideal one here?
Balanced crystalloid.
Normal saline? So normal saline is the only fluid that you will not give. Okay, now why would you not give normal saline? Because that is the only fluid, which is not normal. Okay, because normal saline is what? Normal saline contains 153 milliequivalents of sodium and 153 milliequivalents of chloride. Your body does not contain this only. Your body does not contain it. You understand? Your chloride in your body is 90. Your body contains 135 of sodium. So when you want to give large volume resuscitation with normal saline, you may cause an entity called as hyperchloremic metabolic acidosis. Not only that, chloride is supposed to cause a little bit of a problem. This hyperchloremic acidosis is known to cause problem with the kidney. It is known to cause problem with the kidney, causing further acute kidney injury. Are you understanding? So one of the fluids I may not want to give if I am thinking of a large volume is normal saline. Small volumes will not make a difference. So you are right if you say I am going to give a small volume. But if you are giving a large volume, I will probably not be the right drug to be given, right fluid to be given. So which fluid? Sorry? Balanced salt solution. Okay, so Supriya says balanced salt solution. Anyone who wants to differ? Huh? So where? So how it comes over here is, where comes your investigations? So in your investigation, there is one investigation that you have missed out. Which is that investigation? ABG. Exactly. You missed out on ABG. Okay. So that ABG is very, very important. And what does that ABG do? What does that ABG do? It gives you the acidosis. It gives you the acidosis. Now over here, I am looking at acidosis as a part of the kidney failure. I am looking at acidosis as part of the kidney failure. Acidosis is not coming in from any other source. It is coming from lactic and uremic. This is how it is coming because there is kidney failure happening. Of course, the creatinine is not reflecting that, but it is obvious that the urine output has been low for the last 10 hours. Okay, so you are dealing with something like a kidney failure, isn't it? Huh? Right. Kidney failure here? Huh? Are you understanding this? So where are we at this moment with this ABG? We are looking at bicarbonates. We are looking at bicarbonates. Why are we looking at bicarbonates? Because what we know from bicar ICU trial, is if the bicarbonates are low, when I say low it means less than 17. When I say it's less than 17, what are we dealing with? We are dealing with acidosis that is coming from uremic origin, which can be treated by giving isotonic bicarbonate. So if I have uremic acidosis, and an acute kidney injury, my IV fluid of choice there would be what? Isotonic bicarbonate. What is it? And how do you prepare isotonic bicarbonate? When I say isotonic, is what did I explain to you about the sodium in your body? 145? So 135 to 145 is the sodium in your body. I want to get it to 145, somewhere around that. So what do? I take 500 ml of fluid or say 1 liter of 5% dextrose and I add 150 ml of bicarbonate. When I add 150 ml of bicarbonate in 1 liter, that means it's 150 milliequivalents, right? It's 150 milliequivalents that is going. It's closer to your body. So this becomes isotonic bicarbonate. You understand? So if I want to resuscitate a patient on fluids, with a patient who's got uremic acidosis and the patient has got AKI, my answer would be to give isotonic. Clear on this? Clear? Any doubts here? Work. So we had a situation where our patient, a 60-year-old respiratory tract infection, who basically came with low blood pressure. We resuscitated this patient, but the urine output is low. You've done an ultrasound. There is no postrenal cause for this. You have done a urine analysis. You didn't find anything specific, but you sent electrolytes. Now in these electrolytes in ABG, you find bicarbonate should be less than 17 and going towards acidosis front. Right? So when you are going into high anion metabolic acidosis, this is high anion metabolic acidosis, with the presence of urine output that is on the lower side, my fluid of choice would be actually isotonic bicarbonate. Now how does this work? 100 ml of isotonic bicarbonate actually causes, 100 ml of bicarbonate causes a rise of bicarbonate by 3 milliequivalents approximately. Okay, that's the number. When you give isotonic bicarbonates 100 ml, you will get around 3 milliequivalents to rise. So we are giving around 150 ml. So we are expecting it to go more than 3 milliequivalents per liter. Right? So if I repeat my bicarbonate after a couple of hours, what do I get? I will probably see this going higher. Clear? Now I have a situation where the bicarbonates are normal. Bicarbonates are normal. Okay, you have the bicarbonates to be normal, 20, 21, 22. It is not related to acidosis from here, from this acute kidney injury. There is where I will use what Supriya said. What does Supriya say? I will use a balanced crystalloid. I don't need to use capital. I can use a simple balanced crystalloid like Ringer's lactate.
Ringer lactate.
Okay, I can use a simple, this is Ringer's lactate. Okay, and you don't have to be worried about the fact that the potassium is on the higher side. It doesn't do anything. Okay, your potassium will not cause any problem. Why will it not cause a problem? Supriya, if your potassium was 5.7, would you give Ringer's lactate? Why? Oh, recollect as potassium, right? You give it?
It's very low.
Huh?
Very low.
It's got 5. So 5 milliequivalents per liter. We are in 70 liters in our body. It's not doing anything. If at all, it will. If at all, then it will actually get it down. If at all, because dilution, no, because you're giving less amount, so it will actually try to get it down rather than actually increase it. If at all, so I can give reverse lactate as my balanced crystalloid over here. Clear on this?
So what about lactates?
No problem. Again, the lactate in that is not lactic acid. It's a salt. Okay, it's not lactic acid. So lactic acidosis is not going to occur. What you are having is ringer lactate, which is a salt. It doesn't cause any problem. Okay, so in short, you understood the fluid that we need to give here. Any doubts on this?
So balance crystallized, when do we give this in?
So can you even answer this question?
When bicarbonate is normal.
Yes. So when you have a patient with bicarbonate is normal, okay, there is no role. The bicar ICU trial, there was a trial called as bicar ICU. Okay, bicar ICU. You must know this trial. It is a very important trial. Which actually, what they did was they gave bicarbonate to patients who had uremic acidosis, and they found out that those patients who had uremic acidosis, they were able to avoid dialysis. They were able to avoid dialysis. This is what they found out. They didn't find that the kidney became better or mortality changed, but they were able to avoid dialysis, and that's one of our very hard endpoints, trying to avoid the dialysis, isn't it? So what happens? That's why we are giving isotonic bicarbonate for those patients who got uremic acidosis. However, if you don't have uremic acidosis, I want to give a fluid, there is no point of giving this, because what will happen if you give this? It is going to not only cause 3 milliequivalents rise of bicarbonate, it will also cause 3 milliequivalent rise of sodium. You understand? It will also cause what? 3 milliequivalents rise of sodium. Jigar. I know next time I wanted to teach. So now we are in a situation where we are giving fluids. We are giving fluids. Coffee where we decided now giving IV fluid is okay. It is very essential that you avoid giving too much of IV fluid. Now, why can you tell me why too much of anything that is good is bad? Too much of anything is good that is bad. So why would you think that giving more IV fluid can be a problem? Ashok, do you feel that there can be a problem if you go give more IV fluid?
Yes, sir. If there is no urine output, that patient might do volume overload.
But this patient is not a volume overload. This patient is not. See, this patient we have done vascular variation, we are doing PLR and accordingly giving IV fluids, right? Fluid responsiveness is basically it will respond to a fluid. It doesn't mean it's hypovolemic or hypervolemic. When you do passive leg raise, when you do PLR and you find the cardiac output to be increasing, it basically tells you that if I give the fluid will be taken out by the heart. That's all that it tells you. It doesn't tell you whether the patient is hypovolemic or hypervolemic. The mere fact that your pulse pressure variation is high or the PLR is positive doesn't indicate that the patient is hypo or hypervolemic. Are you understanding? Clear on this? So that is why you must be very careful. Very careful. So your clinical skills are very important over here. Now, if you have an obvious intake output chart that says intake is less and output is more, you know this is hypovolemia on the background of that history. If you have a fluid chart that says intake output 2.5 liters positive last 2 days, what is it? It is hypervolemic. Probably hypervolemic, isn't it? It is probably going to be hypervolemic, isn't it? So giving more volume, how can it be dangerous for the kidney?
Workload.
Any idea?
So actually giving more volume and it also destroys the endothelial gland.
No. So what will happen with more volume? So in the kidney what really occurs is, just like how you have perfusion everywhere, you have perfusion in the kidney also. Okay. Now the kidney perfusion is actually the difference between the arterial and the venous side. That's what the perfusion is all about.
Pressure.
Artery to vein perfusion. Artery to vein perfusion. Now if I increase the venous side, that means I raise the CVP. Or I increase the volume. When we are talking CVP means volume is high. Okay. Of course we don't look at CVP as a number. I'm just telling you for the sake of understanding what hypervolemia is. Okay. So if you have large amount of volume on the venous circulation, okay, the renal perfusion, in fact the capsule will get distended. And like how we have abdominal compartment syndrome, you may have something that looks like an abdominal compartment syndrome which is called a renal compartment. You understand? So the kidney capsule will get edematous and that volume will cause more amount of acute kidney injury. You understand? So this movement of IV fluid versus excessive fluid can be alarmingly dangerous. You must be very careful when looking at IV fluids after you have reached a certain urine output. Clear? You understand what I'm saying? After a certain urine output, you must be very careful whether I should give more fluids or not. What happens generally is there is no urine output, chalo और fluid दो, chalo और fluid दो, chalo और fluid दो. वो चलो और fluid दो में you may actually distend the renal capsule.
So how do you find this out?
Very difficult. That's why clinical. That's why it's all clinical. You understand? It's all clinical. You have to be very clinically sound. You have to look at your IO charts, look at your charts. Otherwise, take for example, if you have a patient who is likely to be hypertensive, okay, you are resuscitating your patient. Okay, blood pressure from 110 has gone to 130. It's 130 now blood pressure. It's not 110 anymore. It's 130. Okay, this getting hypertensive. That is one of the patients that may not be hypovolemic. It may not be hypovolemia. You understand? Because there is a good pressure head. If there is a good pressure head, it is probably not going to be hypovolemia. You understand? It doesn't make sense if your blood pressure is 130, 140 that you think that there is dehydration and give more fluid. It may cause problem here. Are you understanding? Oh, this Vexus scoring. Look at the Vexus score. The Vexus score we'll do next time onward. What is Vexus score? We'll do Vexus score, understand renal, IVC, all these things. Hand, capillary fill, touching, warmth. See all those things and then decide. So giving the extra fluid has to be done very, very carefully. In fact, that can injure. Alright. So we didn't talk about fluids. Are we clear about at least some background about fluids? I will say fluid can never be completely clear. First of all. Okay. Some background I've understood when, why, what and what I will not do. What about this one? So now we came to a condition where I want to optimize my hemodynamics. Okay. So what is this? PEP is 110. What is this then? Someone did say vasopressor. Who said vasopressor? What is this then? Vasopressor, I know two different things. So don't say inotropic support. What is vasopressor? It's a vasoconstrictor. Something that constricts. What is inotropic?
Heart.
Improves the heart. So you can't label them both as inotropic. Vasopressor is different. Inotropic is different. All right. So what is this? What do you think you want to do here?
To increase the MAP greater than 65 to maintain renal function.
So there may be a situation where this patient is chronically hypertensive. May be a situation where the patient is chronically hypertensive, but we now know that raising MAP very high is equivalent to keeping the MAP at 65. We know that. However, we can do something called as vasopressor challenge. Now, what is vasopressor challenge? What I will do is I will start the patient on, though his blood pressure is normal, I will start the vasopressor. I will go the blood, I will take the blood pressure 20% above, say 110, I will take it to 130, 140. I will take it to 130, 140 and I will watch what has happened to the urine output. You understand? In the event that the urine output improves, then I will consider that the autoregulation is disturbed and he needs a pressure on the higher side. Are you understanding?
So this is after fluid.
After fluid, you cannot do this before the fluid. That's why we first started by talking about fluid. You understand? This is a challenge. Like how we have fluid challenge, we have gone beyond the fluid challenge, now we have come to vasopressor challenge. Similarly, if you are monitoring and you find the cardiac output to be on the lower side, I will give an inotropic challenge. I will give say dobutamine, okay, and I will see whether that actually improves the urine output. So this is what we have done. We do this regularly. We do it. After we have resuscitated, we look at cardiac output. If the cardiac output is on the lower side, we would give dobutamine. You understand? And we will see for the next couple of hours what has happened to the urine output. In the event that the urine output is improving, I am assuming that probably it's cardiogenic in origin and I will continue the inodrome. In the event that it's a vasopressor challenge, which challenge I would like to give? What is the vasopressor I would like to use?
Dopamine.
It's vasopressor. Okay. In this case, I would like to use vasopressor because most of the trials have actually indicated that vasopressin is a good drug when it comes to kidney.
Renal perfusion.
When it comes to kidney. Okay. So I would probably use either vasopressor, like vasopressin, and I will watch for around 2 hours here for the urine output to improve. In the event that there is no improvement in urine output, I would consider this to be wrong. If vasopressor challenge is not working, let us not do this anymore. Similarly, inotropic challenge with say dobutamine or any of these drugs that will improve the cardiac output and then watch the urine output for 2 hours. Clear? Clear on this? Clear? Any doubts here?
So without starting Noran, we will start vasopressin.
Yes, no problem. It is the same only. It is after all a vasopressor. Only it's acting on different receptors. So it's going to be the same only. Why we are starting vasopressin? Because many trials have actually shown that vasopressor actually prevents renal replacement therapy. You understand? Many trials have said that. That is why in a septic patient, I normally want to start vasopressin very quickly. If you see norethindrome, I say keep the vasopressin. You've seen that, right? Very often I say keep the vasopressin.
Yes.
This is the reason, because it's actually has a beneficial effect on the kidneys when it comes to any kind of resuscitation. Clear? So I probably want to give vasopressor. This is not, we are not doing this vasopressor to maintain a blood pressure. We are giving a vasopressor to give a challenge of that for that blood pressure. So must understand, this is kind of therapy for AKI. Okay, it's not something that we are trying to do otherwise. We are doing this on a regular basis to see what is happening. Right? Now, in the event that you have given the fluid, there has been no improvement. You have given the vasopressor, there has been no improvement. Now you have decided I can't give any more fluid. Then comes a last challenge, which we call as a diuretic challenge. Okay. Now, what is this diuretic challenge? She did mention one note on the diuretic challenge somewhere. You did mention. What is this diuretic challenge? What is it? So we talked about fluid challenge, we talked about vasopressor challenge, now we are talking about diuretic challenge. So diuretic challenge is called as something called as FST, furosemide stress test, which we do regularly. Which you will not realize that what I am doing is an FST, but you will now recollect when I am talking to you. What is an FST? Okay. Now what is a furosemide stress test? I have given the fluid, I have given the vasopressor, and then the next step I give is 1.5 milligrams per kilogram of furosemide. 1.5 milligram per kilogram of furosemide. Okay, this is what is the dose that you're supposed to give. So 1 to 1.5 kilograms. So 1.5 for those patients who's not furosemide naive. That means if the patient has already received some furosemide in the past, recent past, I keep 1.5. Otherwise, even 1 milligram per kilogram should be adequate. Okay, I will give that furosemide. The test says I give the furosemide, and 2 hours later, in the next 2 hours, I'll watch for urine output. If the urine output goes more than 200 ml or 100 ml, then I will consider my furosemide test to be positive. Furosemide test, challenge test to be positive. What does that mean? What does that mean, Kanchan?
That means its tubular interstitial structure is intact and there is still chance for the reversal.
Very good, very good. So it's not really that much. It's much more than that. What is more than that? So you're right. You said the word intact, right? But there are many things that are not intact. Urine will come only when there is filtration beyond the glomerulus. Right? That is the first thing.
Filtrations.
So, exactly. So, this means the filtration is now happening. Okay. GFR is not that GFR that we are trying to calculate, it's not very poor. It means filtration is happening. First thing. Second thing, it is also telling me that my proximal convoluted tubule is okay. How does it tell me that? Because furosemide dose reaches PCT and then acts. You understand? It has to reach the proximal convoluted tubule. That means my GFR is proper. Okay. It also means that my proximal convoluted tubule, that is where the furosemide is coming. It has to be transported to the PCT. So if it is getting transported to the PCT, that means my cells are working. It's no longer necrotic. It's no longer acute tubular necrosis. You understand? And the third important thing is that further ahead you have the loop of Henle. Where does this work? It works on the loop of Henle. That means not only is my filtration right, my proximal convoluted tubule is also working, also my loop of Henle is working. So it basically tells me that the kidneys are still salvageable. It is not a patient that will go into dialysis. So there is a possibility that I may be able to avoid the dialysis. Are you understanding? Other way around, if I do a FST and 2 hours later the urine output has not improved, what does it say? It's a furosemide stress test negative. When the furosemide stress test is negative, what does it basically tell you? That this kidney, I cannot push too much, I may require dialysis very soon. I'll keep my thinking this way, that I may require dialysis very quickly. Clear? Clear with this? So when I'm treating AKI, I have to follow an algorithm this way. Alright. Okay. Only then I'll decide about dialysis. So when you come to that last statement of yours about dialysis, it comes now. Okay. Now,
FST includes only bolus doses, not the infusion.
no, it's just bolus. Then you can do whatever. So, if by any chance the bolus dose has been given, I know that there is something I can do to get that kidney right. It may be either vasopressor, or it may be fluid, or it may be diuretic. Are you understanding? Because I know there is a margin where I can protect this kidney because this is working. Since this is working, now I am thinking, okay, this may improve. I have to understand further. Maybe I have to reduce the volume. Maybe I have to give diuretic. So normally when you are giving diuretic, what is happening? when you give diuretic, what is happening? All the capsule that has been swollen up because of the excess amount of fluid will actually dehydrate. Once the capsule gets dehydrated, there is a possibility that the urine output will improve. All your volume that you have given, probably diuretic. So generally, when we start 80 milligram, we start 4 ml per hour. What is actually maybe happening inside the body is the fact that you are now removing the fluid excess that was there in the body, which is actually causing the capsule to distend, your kidney capsule to distend, which is dropping the perfusion. Are you understanding? This might be occurring at that time, most probably.
So sir, when fluid challenge is given, then we should start with diuretics,
No,
or we should go with vasopressors.
you will try. This is not challenges, na? I cannot say do this, do this, do this. It's a trial. 2 hour trial here, 2 hour trial here, 2 hour trial
Like
here.
a person with normal cardiac function, fluid challenge, and then we can give diuretic challenge.
After fluid challenge, no, I will probably give you a suppressor challenge. I will try this, no. Diuretics, remember this. All drugs you give are going to be nephrotoxic. Remember this. When you are giving a diuretic, means you are making the kidney work very hard. When you are giving a diuretic, means you are making the kidney work very hard. But at the end of the day, it has to transport the diuretic by that sodium co-transporter into the proximal convoluted tubule. Then it has to act on the loop of Henle and cause that osmotic tendency to cause diuresis to occur. You understand? It has to cause that forced diuresis to cause. So it's basically work on the kidney. The mitochondria has to work excessively. So I would probably not do that. You understand? Logically speaking, I would do that last. Logically speaking, I would first do this, then I would do this, because essentially diuretic is going to be harmful. Essentially, okay.
So it will be like almost 6 hours by the time.
Yes. That is why our definition says what? 6 to 12 hours. No. What is stage 1 AKI?
6 to 12
What is stage 1 AKI? 6 to 12 hours. Less than 0.5 ml per kilogram per hour in 6 to 12 hours. You understand? The definition follows exactly what we are talking. Even after 12 hours, if it's still there in the urine output, I'll call it stage 1. Beyond 12 hours, I'll call it stage 2. It's the staging is also based on that. You understand? You wait. Okay. Simple. Let me go back to another situation. You have a patient whose creatinine is stable. Today, morning, evening, night, it has remained the same. There is no urine. There are two possibilities. One possibility is the fact that the kidney is just hypoperfusing so that it just rests. That's why the urine output is low. You understand what I'm saying? I'll explain to you once more. You have a patient. Let's take the example of bed number 1 Bulani. So 2 days ago, there was a drop in the urine output in the night. Someone called me. Who called me? Yeah, you called me, right? What did I say?
Will wait.
Why did I say I will wait? So what happens usually? What happens usually is, if by any chance there is going to be a drop in the urine output, but the creatinine is stable, in fact reducing. Okay, the creatinine is reducing. Okay, but still, but urine output is dropping. What can I assume? That most probably one of the things that may be occurring is the kidney is hypoperfusing itself. It is reducing the perfusion to itself so that it can rest. It can just rest for a while and then urine output will start up again. Are you understanding? Then urine output will start up again. Oh, you understand? So I am not worried. I am not worried if the creatinine is stable and the urine output is reduced. Other way around, I am not worried if there is excessive amount of urine output and the creatinine is going up. I am not worried about that also. That side also I am not worried. You understand? Because at the end of the day, it's a function that involves everything else. Clear? There's no worry. You have to be very careful on that. Clear? Now, we have gone through all these things. There are another few things that we need to look into. What are the other few things we need to look into here? So, you will look into the phosphorus here. You will look into the phosphorus here. Because what can occur is there can be extreme hyperphosphatemia. Okay, so when there is extreme hyperphosphatemia, what would I want to give? I want to give a phosphate binder. And the phosphate binders that we know are calcium acetate and sevelamer. Right? So I will start the patient on sevelamer, I will start the patient on a phosphate binder somehow. Okay, calcium acetate or maybe sevelamer. This is something I would want to start in the event that I get the phosphates to be on the higher side. Now let me give you another situation. This situation is such that this patient was there and then now becomes extremely drowsy and unresponsive. Now what is happening? So first of all, it is very easy for an acute renal failure to go into uremic encephalopathy because it's not compensated. CKD is compensated. तो तुम्हारा creatinine 8 है, 9 है, 7 है, They are compensated. They don't go into encephalopathy. Now you've seen patients of creatinine, right? 7 and 8 talking to you normally. There is nothing specific on them. You do flaps, they talk to you, right? But an acute renal failure can go into encaph much quicker because of the fact that he's not used to that creatinine going up or that kidney functions to be low. You understanding? Huh? So what do you do in these cases? So you'll have to rule out everything else. You'll have to rule out that there is meningitis. You'll have to rule out that there is vasculitis. You'll have to rule out that there is something else causing in the brain like an infarct. You'll have to rule out all those things, because when you rule out all those things, only you can say it is because of the acute renal failure. So what do you do to rule them out? What do you do to rule them out? So you see the situation is now changed. This patient was there, and urine output has been low, but now he's become unresponsive. He's become very drowsy. So in your mind you have to think, what am I dealing with here? What am I dealing with? Of course, what I told you now is to tell that it is because of renal failure that this patient has had this drop in the GCS. I need to rule out everything else, because there is no test I can do for uremic encephalopathy. You know, there is no test I'll say karo uremic encephalopathy. So what do? I rule out everything else. How do I rule it out? Exactly, I'll do an MRI. What does the MRI show me? If there is infarct, but otherwise what can it show me? What can it show me? So if your patient of acute renal failure is there and you do an MRI, you can see 3-4 things. You can see something called basal ganglia hyperintensity. This can occur in patients who have been kind of a little bit renal failure, CKD a little bit. Okay. You can also see something called as lentiform Fock sign. Now what is lentiform Fock sign? You have the ventricles, and then you have this kind of structure like this. ऐसा उसके बाजू वो रहता है वेंट्रिकल के बाजू में. This will look like a fork, lentiform Fock sign. This is what you can see on an MRI. Of course, you rule out infarct, you rule out hemorrhage, you rule out all those things. But this is something that you commonly see. You may commonly see basal ganglia hyperintensity, and you may see lentiform Fock sign. Okay, so you should not see that and say this is something that has occurred. But in this uremic condition, you might see these things. Understand? Now you have ruled, you have done an MRI. That's why if you look at Bendabar Pushpa, what we did, we got the MRI. She was drowsy, right? So you see AKI, how we have treated that patient. It's exactly what the guideline says. Okay, that's why I was insistent, get me the urine analysis, get me the urine analysis. I was telling again and again, I want the urine. I've been telling that again and again, is it? So then what we did after this MRI in this particular patient? CSF. So now what do I do after that? I do a CSF. Now, in a patient of renal failure, the CSF can show the proteins to be more than 100. It can show that the proteins can be more than 100 and CSF can be normal, otherwise WBC can be normal. What do we see in him? What do we see in her? Protein was more. But I don't want to be saying that this is because of renal failure, because I have to exclude everything else. And my exclusion requires encephalitis to be ruled out, which is autoimmune encephalitis. You understand? That's why what did we say yesterday? NMDA receptor antibodies. You understand? Then I'm assuming that this probably the reason for this patient's extreme drowsiness is actually urine. You understand? Uremia. The extreme drowsiness is because of that. Clear?
Sir, we cannot do ammonia only like first.
What are we dealing with here? A patient who had. Do you have a reason for the ammonia to be high here? Then you cannot do investigations to find out something unless you have a documentation of the clinical feature in your mind. You can't do 15 investigations and say this came positive. ऐसा नहीं करते. हम लोग सोचते हैं कि in those 15 investigations, because my clinical state is this, I would do 2. समझ में आ रहा है? It is very wrong to send a battery of investigations and then figure out something from that. Okay, what you're supposed to do is clinically assess this patient and what are my likely problems. Is this my likely problem? So I will send that investigation. In this case, do you think that the ammonia can be a problem? No, because liver functions were normal, comorbidities are not there, there is no cirrhosis, there is no hepatic encephalopathy in any way. Then why could do an ammonia? Are you understanding? There is no reason to do it. Clear? Here what am I looking at? Uremic. Our thinking was I want to rule out uremic. I want to say that this is not, to rule in uremic, I need to rule out everything else. And that is what I did. What did I do? I did everything else to actually rule out uremic encephalopathy. Now if you follow Pushpa, what exactly we did? We exactly did these things. If you look at what we did with Pushpa, we did the same thing. Initially she came, we gave her fluid challenge, she didn't improve. We gave her we put her on a small dose of vasopressor and we tried whether that improves urine. It didn't improve. It didn't improve, right? After that we gave her a diuretic. It didn't improve. It didn't work. So what we did? Dialysis. We did dialysis because we just did it because there is no chance that it can occur because electrolyte abnormalities started occurring. Sodium went from 130 to 150. Electrolyte abnormalities came in. Electrolyte abnormalities came in. There were problems. The kidney was unable to handle that. So what we did? Dialysis. The post dialysis, what we noticed? Okay, let me now. I still feel the kidneys might work. I still feel the kidneys might work because it was responding to a diuretic challenge. It was responding to a diuretic challenge. So, the moment we gave diuretic, what happened? Urine output picked up. So, we are coming to this arm, diuretic channel, where the kidneys kind of can pick up. So, now what is my thinking? No. I need to optimize her better. Let me optimize her better. To optimize her better, let us try to diurese as much as possible. Okay, so diuresis has been started because we have loaded with fluids in the past. So now we diurese. As we diuresing, our urine output is improving. So I am not concerned about the creatinine now because the creatinine is going up because of the insult that occurred some days ago. Are you understanding? So we are actually following exactly this protocol. There is no difference in the protocol that we just now followed. It's exactly what this is. That's why I say critical care is algorithmic. If you do it as per algorithm, it is very simple. If you think of all sort of things around the world, it is not simple. It becomes very difficult. So if you now think about how to approach AKI, you will find it very simple. If you now think how to approach AKI, otherwise when you actually showed all these things, it became very difficult. It became so much. अरे यार इसका ये सब ये डर लगता है देख के. But when you now look at this, it becomes very simple. The management. Clear? Any doubts on this? So can you make a flowchart, Kanchan? The way I made it. So you make a flowchart, give it to me, and I'll probably put it on the website. If anybody wants to read it, they can just read it. It's simple. So you're going to put a flowchart that says management of AKI, ultrasound, sonography. Sonography, you do what you want to see in the sonography, and then you'll say is urine analysis. In the analysis, what I want to see, then what investigations I want to send with respect to AKI, and then about fluid challenge. With respect to IV fluids and which kind of fluid I want to use, when I want to stop the fluid, when I want to ensure hypervolemia. Vasopressin challenge, I wait for 2 hours and see after raising the blood pressure with the vasopressin. Okay, and a diuretic challenge, following which I would see whether diuretic responsiveness and if it responsiveness, what does it indicate? Right? And the management will also talk about the fact that even if the creatinine is elevated, my antibiotics will remain the same. So that is the flowchart I want. Okay? And you'll also talk a little bit of urine analysis as to what I'm going to look at. WBC count, body cast is ATN, WBC cast is interstitial nephritis, and RBC cast is glomerular nephritis. Proteins very high glomerular nephritis, lesser than that, less than 2, it is interstitial nephritis. Right? These are the few things I'm going to see. Alright?
Sir, supposing they reach a stage where they need to be dialyzed, so the family sometimes ask us like, is this dialysis going to be permanent, like how to answer?
Normally the right answer to tell them is that we cannot tell you till 1 month. Any tissue in our body to heal takes 4 to 6 weeks. Let it be any tissue in our body. If it has to heal, it will heal in 4 to 6 weeks. Right? So you will say 50% of the chances are that it will be a permanent dialysis. Okay? But this we will know only after 1 month. You understand? Clear on this? If the urine output starts coming early, we can assume that the kidneys have started working. You have to tell them like that. So how many times dialysis are required? It depends on the requirement. If the potassium goes up, if the patient cannot remove the toxic products, I probably want to do dialysis. This is how we talk to the family. You understand? And classically, this is what occurs also.
Because some of them are like very reluctant to dialyze.
Yeah, because you have to explain this to them. Because they are reluctant, why? Their thinking is 100% that if I start dialysis, it will be permanent. This is their thinking. So you don't let them know that thinking, put it as 50%. But that 1 in 2 people will require dialysis permanently. You know, when I talk like this now, it is different from when I say 1 in 2 people will not require dialysis after 1 month. You understand? So if I the same statement I have put in 2 different ways. What have I said? 1 in 2 patients will require dialysis permanently. 1 in 2 patients will not require dialysis after 1 month. So it's 2 different actually the same statement said differently. But it sounds better when you say that after 1 month probably there may be a chance that she may walk off the dialysis. That is how, because you know this is a correctable cause, no? It's a correctable cause. Okay? Especially AKI. CKD is a different ballgame only. AKI. This is AKI. You know, we're not saying that the kidney is completely damaged, it's acute kidney injury. But usually what you can understand is by a diuretic challenge. If a diuretic challenge doesn't actually improve now, the chances of the patient having a reversal of the entire AKI is very less likely. This is for clinically. They generally end up getting dialysis. But dialysis can be for 1 month and can be even before that. Okay? Any other questions?
So this AKI definition, it basically includes the functional capacity of the kidney.
Yes.
I mean to say, so like if unilateral kidney is damaged, one-sided or it's absent, still we won't be able to call it. Or if there is scarring in one kidney and one kidney is normal, that time we will not term it as AKI.
No, because that's why the AKI, the definition has got its own inherent problems. If you look at it, I'm not worried if the creatinine is normal and the patient is having no urine output. I'm not worried. It will start coming sometime. I'm not worried if the urine analysis is urine is coming very low for the last 12 hours but my creatinine is stable. I'm not really worried. You understand? All these are just guides to stage a disease, a guide to actually tell you what treatment should slightly change, or a guide to actually put in various trials. For example, randomized control trial I want to do in stage 1 or a stage 2 or a stage 3. You are understanding? So if I want to do a trial on a certain stage of the disease, I will lead the stage. So many of these things help in many other, all these classifications not only help you in guiding you, it also helps you in all of these other things. Stage 1, stage 2 and stage 3. Clear? So next time, not to remember these things, no, what you should do is,